This is Suicide Prevention, Module 1. Someone dies by suicide every 15 minutes. In 2013, more than 41,150 Americans took their own lives.
That brought us to that day when I think he felt so bad and he was kind of depressed that he suddenly decided that he couldn't do it anymore. So he just said he was going out to the cafe to have a cup of coffee, and he went straight into the subway and under the train. And that was it.
On January 27, 1998, Guynell ended his life. He was 19 years old.
Depression is a major risk factor for suicide. The deep despair and hopelessness that goes along with depression can make suicide feel like the only way to escape the pain.
Depression is very hard to describe. It's not so much a thing as a lack of. It's like a dark cave, devoid of feeling, devoid of light, nothing to look forward to. It's a horrible state of non-existence.
Depression is defined as a mood disorder that causes a persistent feeling of sadness and loss of interest. It affects how one feels, thinks, and behaves, and it can lead to a variety of emotional and physical problems. One may have trouble doing normal day-to-day activities and may feel as if life is not worth living. The common signs and symptoms of depression include that feeling of hopelessness and helpless, lost interest in friends, activities, and things that they used to enjoy, feeling tired all the time, sleep and appetite changes. Also, one can't concentrate or find that previously easy tasks are now difficult. They tend not to be able to control their negative thoughts no matter how much they try. And someone with depression tends to be more irritable, short-tempered, or aggressive than usual. They may also be consuming more alcohol than, quote, normal, or engage in other reckless behaviors.
Depression is not simply having the blues. Instead, it's a complex illness that affects mood, thoughts, even the body. It can interfere with a person's ability to work, sleep, eat, and enjoy pleasurable activities.
I think the thing that separates depression from, in a sense, run-of-the-mill sadness or loneliness or bad moods, right, is that depression becomes a situation in which one cannot function any longer, right? So one cannot work as they once did. One's relationships suffers. One's standing in the community and the role they're expected to play falters.
In the U.S. alone, as many as 25% of the population will suffer from depression at some point in their lives. Without treatment, it can become debilitating, lasting weeks, months, or even years. The most common symptoms of depression include listlessness, an inability to experience pleasure, and changes in sleep patterns and eating habits. If you are suffering from depression, you might not experience every symptom, and the severity of symptoms varies from person to person. Certain types of depression, like bipolar disorder, can cause some people to experience hallucinations. These can range from hearing or seeing things that aren't there to false beliefs.
As discussed in the previous video, the link between depression and suicide is a strong one. If left untreated, depression can lead to comorbid mental disorders, recurrent episodes, and higher rates of suicide. Thus, a person suffering from suicidal thoughts or behaviors clearly has the potential to be in need of intervention services via the Baker Act.
At its most extreme, depression might lead individuals to harm themselves. It's estimated that as many as 15% of people with untreated depression end their own lives.
If left untreated, depressive disorders can range from, if I might speak crudely, just making your life a shambles, all the way up through and including suicide.
In this module, I'll define suicide and other related terms, discuss the relationship between depression, suicide, and Baker Act admission, assist in understanding the risk factors that lead to suicide, and identifying the various warning signs of suicide with specific information on populations that are more vulnerable to suicide. The definition of suicide is when a person directs violence at themselves with the intent to end their own life, and they die as a result of their own actions. Suicide affects everyone, but some groups are at higher risk than others. Men are 4 times more likely than women to commit suicide. While there is no single cause of suicide, several factors can increase a person's risk for attempting or dying by suicide. Risk factors for suicide include previous suicide attempts, a history of depression or other mental illness, alcohol or drug abuse, family history of suicide or violence, physical illness, or feeling of being alone. The definition of mental illness under the Baker Act, 394.455, subsection 18 of the Florida statutes, reads, an impairment of the mental or emotional processes that exercise conscious control of one's actions or of the ability to perceive or understand reality, which impairment substantially interferes with the person's ability to meet the ordinary demands of living. For the purposes of this section, the term does not include a developmental disability as defined in Chapter 393, or intoxication, or conditions manifest only by antisocial behavior or substance abuse impairment. It's important that you understand and know that definition of mental illness, because to be Baker acted, both the criteria that I just read need to be in place. The clinical component, meaning an impairment of mental or emotional processes that exercise conscious control of one's actions or ability to perceive or understand reality, and that functional component, meaning it substantially interferes with a person's ability to meet the ordinary demands of living. Suicidal behaviors arise from complex interactions between psychological, biological, genetic, sociological, and economic factors. Due to the numerous variables, including risk and protective factors, impacting suicide risk, accurate prediction of future suicidal behavior is difficult. Risk factors are characteristics that increase the possibility an individual will harm themselves, although risk factors do not themselves necessarily cause that self-injury or death. Although suicide can affect anyone, the following populations are known to have an increased risk for suicidal behaviors. They include individuals with mental illness and or substance use disorders, individuals that are bereaved by suicide, those that are in the juvenile justice or child welfare settings, individuals who engage in non-suicidal self-injury, those folks who have attempted suicide, individuals with medical conditions, individuals who are in the lesbian, gay, bisexual, or transgender community, American Indians or Alaskan Natives, members of the armed forces and veterans, men in midlife, and older men. Let's discuss some useful terms that will help you to better understand the content as you go through this training. Suicide-related ideation are thoughts of engaging in suicide-related behavior. Sometimes these thoughts include a specific suicide plan and sometimes not. They can be with, without, or undetermined intent to kill oneself. Suicide-related communication has to do with any communication regarding potential self-inflicted death. Intent to kill oneself is present, or it might be undetermined. This communication can be verbal or nonverbal, and the individual may or may not mention a specific plan. Suicidal behavior includes a preparatory behavior of self-inflicted, potentially self-injurious behavior that includes an intent to die. The National Strategy for Suicide Prevention, Goals and Objectives for Action, provides a framework for risk factors. Risk factors may be biopsychosocial, environmental, or sociocultural in nature. Although this division is somewhat arbitrary, it does provide a framework to think about factors from these different perspectives. Our emphasis should not be determining the correctness or incorrectness of the categories, but the focus should be on identifying and considering all risk factors. Some of the biopsychosocial risk factors include mental disorders, particularly mood disorders, schizophrenia, anxiety disorder, and certain personality disorders, alcohol and other substance use disorders, hopelessness, impulsiveness or aggressive tendencies, a history of trauma or abuse, some major physical illnesses, previous suicide attempts, and a family history of suicide. Some of the environmental risk factors would include job, housing, or financial loss, relational or social loss, easy access to lethal means, and local clusters of suicide which have a contagious influence. Some socio-cultural risk factors would be a lack of social support or sense of isolation, stigma associated with with help-seeking behavior, barriers to accessing health care, especially mental health and substance abuse treatment, certain cultural and religious beliefs, for example, the belief that suicide is a noble resolution of a personal dilemma, and exposure to and influence of others who have died by suicide. Researchers have identified what might be considered generic factors for suicide that cross age, economic, and other population criteria. They include prior suicide attempts, a history of mental disorder, particularly that depression and alcohol or substance abuse, family history of suicide, acute or chronic losses, chronic physical illnesses, particularly associated with chronic pain, easy access to lethal methods, impulsive or aggressive tendencies, feelings of hopelessness or isolation, recent or perceived losses, be it physical, financial, or personal, stressors, triggering events leading to real or perceived humiliation, shame, or despair. Along with depression, being widowed and physically ill are particularly important risk factors for suicide among men over the age of 65. Individuals over 65 constitute 13% of the general population, but account for almost 20% of total suicides annually. While women more frequently attempt suicide, although almost 4 times as often as men, the men actually die by suicide. This is due in part to the tendency among men to use more violent methods, such as firearms and hanging, and their refusal to seek or consult a mental health professional when experiencing suicidal ideation. Approximately 90% of suicides in the U.S. are associated with a diagnosable mental and/or substance abuse disorder. Among the approximately 32,000 people in the U.S. who die by suicide each year, an estimated 20 to 35% alcohol abuse or are drinking at the time of their death. Individuals suffering from alcoholism are 5 times more likely to die by suicide than other individuals. Alcohol impairs judgment and lowers inhibitions, while the depressive effects of alcohol can exacerbate an existing mood disorder. Among individuals with co-occurring major depressive and alcohol disorders who are admitted to a psychiatric hospital, almost 40% have attempted suicide in the week just before admission. Most of these individuals report that they drank more heavily than usual on the day of their attempt. It is estimated that 50% of the individuals who die by suicide were afflicted with a major depression, and the suicide rate of people with major depression is 8 times that of the normal or general population. Suicide was the second leading cause of death for individuals 15 to 24 years old. It ranks third among children 10 to 15 years of age. The prevalence of suicidal thoughts, suicide planning, and suicide attempts is significantly higher among young adults than it is those adults aged 30 or older.
Some are suicidal.
I was trying to kill myself so I could be with my mother. That may be hard to understand, but I feel as though once you're dead, you'll be able to be with the other people that are also dead.
When you started cutting at yourself, what was going on inside your head?
I just wanted to die to be with my mom. I didn't care no more. I didn't care about nobody no more.
Are you going to stay alive or are you going to die?
That's a tough question to answer because I don't know.
Risk factors do not establish a cause of suicidal behavior. They only describe an association. The following list is not complete, but it does show the most important risk factors: mental illness and substance abuse, previous suicide attempts, firearms in the house, non-surgical self-injury, exposure to friends or family members' suicidal behaviors, and low self-esteem. Bullying involves an imbalance of power. Typically, those who engage in bully-like behaviors use their strength or their popularity or power to harm, control, or manipulate others. They will usually target those who are weaker in size or may have a difficult time defending themselves. Intent to cause harm. A bully is a person who does not do things by accident. The bully intends to physically or emotionally injure a person or a group of persons. Typically, incidents of bullying are not a one-time thing. Bullies target the same person or group over and over again. The different types of bullying include verbal, which is the usual kind of name calling and or teasing; social, spreading rumors, intentionally leaving others out of activities on purpose, breaking up friendships. Those are all examples of social bullying. Physical bullying is the traditional form of bullying which involves hitting, punching, shoving, and other acts of intentional physical harm. And then there's cyberbullying. This method of bullying involves using the internet, texting, email, and other digital technologies to harm others. Bullycide is a relatively new term. It's a hybrid of bullying and suicide that's used to explain when someone takes their life as a result of being bullied. Children and teens who are bullied live in a constant state of fear and confusion in their lives. Many feel that the only way to escape the rumors, insults, verbal abuse, and terror is to take their own life. Some of the statistics regarding bullying and suicide include the fact that suicide is the third leading cause of death among young people. According to the CDC, for every suicide among the youth, there are at least 100 suicide attempts. Bullying victims are between 2 to 9 times more likely to consider suicide than non-victims. And another study from Great Britain found that at least half of the suicides among young people there were related to bullying. 10 to 14-year-old girls were in the highest risk of suicide according to that study. Approximately 160,000 children a day stay home from school in the U.S. because of fear of bullying. Bully-related suicide can be connected to any of those types of bullying that I just presented: the physical, the emotional, the cyberbullying, sex texting, or circulating suggestive or nude photos or messages about a person are also forms of that bullying that affect them to such an extent. The American Association of Suicidology stresses that warning signs are the earliest detectable signals that indicate heightened threat for suicide in the near term. That may be within minutes, hours, or days, as opposed to risk factors, which suggest long-term risk, perhaps a year to a lifetime. Warning signs are, quote, red flags, unquote, that an individual may be at risk of suicide. People at risk may not immediately volunteer the fact that they're considering harming themselves directly to others. However, they often provide clues or warning signs. Sometimes different people may be aware of some but not all of the warning signs in a particular case. Additionally, long-standing, chronic, or permanent risk factors, like the mental illness, history of past suicide attempts, etc., must be taken into account when considering warning signs in order to sufficiently assess those at risk of dying by suicide. Also consider the current state of the individual during the assessment. Depression is a major risk factor for suicide. If someone with depression presents any suicidal talk or behavior, learn to recognize the warning signs. They include talking about killing or harming oneself, expressing strong feelings of hopelessness or being trapped, an unusual preoccupation with death or dying, acting recklessly as if they have a death wish, for example, like speeding through red lights, calling or visiting people to say goodbye, getting their affairs in order, like giving away prized possessions or tying up loose ends, saying things like, everyone would be better off without me, or I want out. A sudden switch from being extremely depressed to acting calm and happy.
How do you remember the warning signs of suicide? Here's an easy to remember mnemonic. Is path warm? I, ideation. S, substance abuse. P, purposelessness. A, anxiety. T, trapped. H, hopelessness. W, withdrawal. A for anger, R recklessness, and M mood changes. Is path warm?
The following warning signs require immediate action and safety measures. When an individual starts talking or writing about suicide, death, or dying, if they are giving direct verbal cues such as "I wish I were dead" or "I'm going to end it all," or looking for ways to kill themselves, like seeking access to pills, weapons, or other means. The following warning signs warrant attention, especially if present with known risk factors: hopelessness, increasing alcohol or other drug abuse, global insomnia, isolating themselves from friends and family, dramatic changes in mood, neglecting their appearance and personal hygiene, acting reckless or engaging in risky activities, or indicating no reason for living or no sense of purpose in life. These warning signs are especially critical if the individual has a past or current substance abuse disorder or psychiatric diagnosis like depression, anxiety, or panic disorder, bipolar disorder, or schizophrenia. An individual's age, culture, and religious beliefs may influence how they convey the warning signs. The following series of slides highlight some of the major populations at risk of suicide and the unique warning signs associated with each.
Adolescents' warning signs tend to be somewhat different from the elderly, and those assessing risk should be alert for volatile mood swings or personality changes, unhealthy indications, bruises, or other injuries, particularly those they refuse to explain, a sudden deterioration in personal appearance, self-mutilation, a fixation with death or violence, eating disorders, especially combined with dramatic shifts in weight, other than those associated with, a diet under medical supervision, gender identity issues, and depression.
Depression is common among teenagers. Some of the problems and symptoms that teens with depression experience include feeling that they're irritable, sad, or angry, that nothing seems fun anymore, and they don't see the point of trying. They may feel bad about themselves, worthless, guilty, or just, quote, wrong in some way. They tend to sleep too much or not enough. They have frequent unexplained headaches or other physical problems. Anything and everything can make them cry. You could see that there is a weight loss or weight gain without consciously trying. Also, they may have difficulty concentrating. Their grades may plummet as a result. They may feel helpless and hopeless, and they may be thinking about death or suicide. Some of the signs that a child is a victim of bullying include if they come home with unexplained injuries or with damaged or missing clothes or other belongings, if there's a change in their eating habits, or if they make excuses not to go to school, if they have fewer friends than they had, if they feel helpless, talk about suicide, act out of character, avoid certain places or playing outside alone, if they feel like they are not, quote, good enough, unquote, if they have trouble sleeping, or if they blame themselves for their problems. It is important to recognize the signs of bullying. Bullying effects can lead to severe depression or even suicide. Many veterans may not show any signs of intent to harm themselves before doing so, but some actions can be a sign that a veteran needs help. Veterans in crisis may show behaviors that indicate a risk of harming themselves. Veterans who are considering suicide often show the signs of depression that we've talked about, the anxiety, low self-esteem, and/or hopelessness, such as they're appearing sad or depressed most of the time. Clinical depression, that deep sadness, loss of interest, trouble sleeping and eating that doesn't go away or continues to get worse, feeling anxious, agitated, or unable to sleep, neglecting their personal welfare, deteriorating their physical appearance, withdrawing from friends, family, and society, or sleeping all the time, losing interest in hobbies, work, school, or other things that once they used to care about, frequent and dramatic mood swings, expressing feelings of excessive guilt or shame, feelings of failure or decreased performance, feeling that life is not worth living, having no sense of purpose in life. They may talk about feeling trapped, like that there's no way out of a situation, or about having feelings of desperation and saying that there's no solution to their problems. Their behavior may be dramatically different from their normal behavior, or they may appear to be actively contemplating or preparing for a suicidal act through behaviors such as performing poorly at school or work, acting recklessly or engaging in risky activities seemingly without thinking, showing violent behavior such as punching holes in walls, getting into fights or self-destructive violence, feeling rage or uncontrolled anger, or seeking revenge. They may be looking as though one has a death wish, tempting fate by taking risks that could lead to death, such as driving fast or running red lights, giving away their prized possessions, putting affairs in order, tying up those loose ends, and or making out a will, and seeking access to firearms, pills, or other means of harming themselves. The changes that often come in later life, like retirement, the death of loved ones, increased isolation, medical problems, can lead to depression. Depression prevents someone from enjoying life like they used to, but its effects go far beyond mood. As we've said, it impacts energy, sleep, appetite, and physical health. Elderly individuals may complain instead of low motivation, a lack of energy, or a physical problem. In fact, physical complaints such as arthritis, pain, or worsening headaches are often the predominant symptoms of depression in the elderly. Careful attention must be paid to elderly individuals who are physically ill and who exhibit any of the following warning signs of suicide: stockpiling medication, buying a gun, giving away money or cherished personal possessions, taking a sudden interest or losing their interest in religion, failing to care for themselves in terms of routine daily activities of living, withdrawing from relationships, experiencing a failure to thrive even after appropriate medical treatment, and scheduling a medical appointment for vague symptoms.
Many older adults visit a primary care physician within a month of dying by suicide. The majority of these individuals had undergone mental illness such as depression or a medical condition associated with an increased risk of suicide, such as diabetes, cancer, especially head and neck, kidney failure, peptic ulcer, or rheumatoid arthritis.
Whatever the reason for the condition, older people tend to display symptoms of depression differently. Often, they complain more about the physical effects of the condition, like aches and pains, rather than the emotional ones, or they may complain of problems with memory or concentration. And depression tends to last longer in older adults than in younger people. Because it can be so hard to separate depression from other conditions in older individuals, And because of the stigma attached to mental illness among this demographic, only 10% of older people with depression receive treatment. This is disheartening because the elderly, particularly men, are much more likely to commit suicide. In fact, people 65 and older account for fully 16% of suicide deaths, despite the fact that they make up just 12% of the U.S. population.
A person who is at risk of committing suicide and presents warning signs as described here may be admitted to a receiving facility for evaluation on a voluntary or involuntary status because their mental or emotional processes are significantly impaired and they are unable to cope with the ordinary demands of living. A person can be on voluntary or involuntary status under the Baker Act. However, to be on voluntary status, a person must not only be willing to consent, but competent to consent to admission and to treatment. If a person is incompetent to consent to treatment, then they can't be held under the voluntary provisions of the law. Incompetent to consent to treatment means that a person's judgment is so affected by their mental illness that the person lacks the capacity to make a well-reasoned, willful, and knowing decision concerning their medical or mental health treatment. A person on voluntary status is presumed to be able to exercise all of their rights under the law, including that of consenting or refusing consent to admission and or to treatment.
Intervention Center and talked to them on the phone. They said there was nothing they could do for me for one night. So I wound up here by ambulance. Paid an ambulance to take me here.
Okay.
Because the crisis intervention couldn't do anything for me.
Have you ever made any suicide attempts?
Oh yeah, I have. A couple of them when I was 19.
Okay. Are you usually able to ask for help when you start feeling like that?
No, I was never able to ask for help before.
Okay, so this is a new thing.
This is
You're
a new
coming
thing
into
for
the
me.
hospital.
Yeah,
Okay.
the way I came in here is unlike any other way I've ever come into a hospital. Asking people to please help me so I do not kill myself.
That's all the questions I have for right now.
Can I go back in now? Yeah, I'm getting very uncomfortable out here. I think somebody might be trying to shoot me. Someone might be trying to kill me.
A facility may receive for observation, diagnosis, or treatment any person 18 years of age or older making application by express and informed consent for admission, or any person aged 17 or under for whom such application is made by their guardian. A person that is 17 years old or under can be admitted only after a hearing to verify the voluntariness of the consent. To be admitted under voluntary status, the individual must show evidence of mental illness, be competent to provide express and informed consent, and be suitable for treatment. Such a person 18 years of age or older may be admitted to the facility at that point. Each person entering a facility, regardless of age, must be asked to give informed and expressed consent for admission and treatment. Before giving consent to admission or treatment, the following information must be given to the person or to their legally authorized substitute decision maker. The reason for admission, proposed treatment, including proposed psychotropic medications, the purpose of the treatment, alternative treatments, specific dosage range for medications, frequency and method of administration, common risks, benefits, and common short-term and long-term side effects, any contraindications which may exist, clinically significant interactive effects with other medications, similar information on alternative medications which may have less severe or serious side effects, potential effects of stopping the treatment, appropriate length of care, how treatment will be monitored, and disclosure that any consent for treatment may be revoked orally or in writing before or during the treatment period by the person legally authorized to make healthcare decisions on behalf of the individual. Within 24 hours after a voluntary admission, the admitting physician must document in the person's clinical record that the person is able to give express and informed consent for admission and treatment. If the person is not able to give the express and informed consent, the facility must either discharge that individual or transfer them to an involuntary status. Implied consent is not sufficient in Florida. Express and informed consent is the legal standard. A person is incompetent to consent to treatment when their judgment is so affected by their mental illness that they lack the capacity to make well-reasoned, willful, and knowing decisions concerning their medical or mental health treatment. Every patient entering treatment shall be asked to give express and informed consent for admission or treatment. If the patient's been adjudicated incapacitated or found to be incompetent to consent to treatment, express and informed consent to treatment shall be sought instead from the patient's guardian or guardian advocate. If the patient is a minor, then express and informed consent for admission or treatment shall be also requested from the patient's guardian. Expressed and informed consent for admission or treatment of a patient under the age of 18 shall be required from the patient's guardian unless the minor is seeking outpatient crisis intervention services. Express and informed consent for admission or treatment given by a patient who is under the age of 18 shall not be a condition of admission when the patient's guardian gives express and informed consent for the patient's admission. The following individuals are authorized to give or refuse consent to treatment orally or in writing before or during the treatment period: a competent adult, guardian of a child, court-appointed guardian, guardian advocate, or a health care surrogate or proxy. Failure by the staff to completely disclose all required information to a person that's authorized to provide consent to treatment means that express and informed consent has not been obtained. Any person, regardless of age, who is admitted on a voluntary basis must be informed at the time of admission of their right to request release. If the person requests discharge, a notice must be given to the person's physician or psychologist within 12 hours. If the competent adult or the minor's guardian refuses or revokes consent to treatment, the person must be discharged within 24 hours of that refusal or revocation unless transferred to the involuntary status by filing a petition for involuntary placement. This is filed with the circuit court within 2 court working days after the request for discharge. A state hospital has up to 3 working days rather than the 24 hours due to the difficulty in making discharge plans from a distance. When a voluntary patient or an authorized person on the patient's behalf makes a request for discharge, the request for discharge, unless it's freely and voluntarily rescinded, must be communicated to a physician, clinical psychologist, or psychiatrist as quickly as possible, but not later than 12 hours after that request is made. If the patient meets the criteria for involuntary placement, then the administrator of the facility must file with the court a petition for involuntary placement within 2 court working days after the request for discharge is made. If the petition is not filed within those 2 court working days, then the patient shall be discharged. Pending the filing of the petition, the patient may be held and emergency treatment rendered in the least restrictive manner upon the written order of a physician if it is determined that such treatment is necessary for the safety of the patient or others.
He's coming in for paranoid schizophrenia. He's hearing voices that want him. He wants to kill himself.
Mr. O'Brien, have you been here before? When was the last time, roughly? April. Which unit?
18.
I'm going to give the clerk your papers. I'm Dr. Reeves. Hi. You were at Beekman downtown?
Yeah.
Did they discharge you on medicine?
Yeah.
Which ones? Do you know?
Risperidol.
And that's all?
That's it.
Okay. Had it been working well for you?
Yeah.
Okay. Had you been taking it?
Yeah, I was taking it. I don't know where my medication is. I don't know if I lost it or what.
Okay. Where do you stay?
I stay in the streets.
It's probably hard to keep up with things, right? You had anything sharp on you?
No, I gave it in.
Okay. You gave it in?
Yeah.
All right. I'll see you in a little bit.
All right.
The Baker Act encourages the voluntary admission of individuals for psychiatric care, but only when they're able to fully understand the decision and its consequences and are also able to fully exercise their rights for themselves. When this is not possible due to the severity of the person's condition, then the law requires that that person be extended the due process rights assured under the involuntary provisions of the law. A person may be taken to a receiving facility for involuntary examination if there's reason to believe that they may be mentally ill, as defined by the law, because their mental illness, 1, they've refused voluntary examination after conscientious explanation and disclosure of the purpose of the exam. The person is unable to determine whether the exam is necessary. Or 2, without care or treatment, this person is likely to suffer from neglect or refuse to care for themselves. Such neglect or refusal poses a real and present threat of substantial harm to the individual's well-being, and it's not apparent that such harm may be avoided through the help of willing family members or friends or the provision of other services. There's a substantial likelihood that without care or treatment, the person will cause bodily harm to themselves or others in the future, as evidenced by recent behaviors. Being willing to consent means that a person has not experienced any force or fraud, deceit, duress, or other form of constraint or coercion to persuade them to sign voluntary admission forms. Being able to consent means a person is competent to make their own decisions. Incompetent to consent is legally defined as having one's judgment so impaired by mental illness that one lacks the capacity to make a well-reasoned, willful, and knowing decision concerning medical or mental treatment. If a person cannot consistently give well-reasoned decisions about their own treatment, that person must be held at a facility under the elevated protection of involuntary status of this law. Some individuals have impairments of thought that may cause them to be unable to fully understand all aspects required for informed consent, and these individuals must be held under that involuntary provision and have a substitute decision maker. Minors are considered incompetent to consent to their own treatment because of their age. Their parent or legal guardian must provide authorization for any treatment that they receive. When somebody is admitted to a facility, they'll be asked to identify someone to be notified in case of an emergency. If admitted for an involuntary examination without a court-appointed guardian, then the individual will be asked to designate someone to receive notification of the admission, unless they request that no notification be made. No representatives are designated for individuals on a voluntary admission. If the person cannot or will not designate a representative will be selected by the facility from a prioritized list. The individual has the right to be consulted about the selected representative and can request that the representative be replaced. In selecting a guardian advocate, the court shall give preference to a healthcare surrogate if one has already been designated. If the patient has not previously selected a healthcare surrogate, then the selection shall be made from the following list in the order presented: the patient's spouse, an adult child, a parent, the adult next of kin, an adult friend, an adult trained and willing to serve as guardian advocate for the patient. If a guardian with the authority to consent to medical treatment has not already been appointed, or if the patient has not already designated a healthcare surrogate, then the court may authorize the guardian advocate to consent to medical treatment as well as to mental health treatment. A guardian is appointed by a circuit court for an individual who is determined to be incapacitated. A guardian can make a wide range of financial and treatment decisions, or they may have limited decision-making powers if only certain rights have been removed from the individual and given to that guardian. A guardian advocate is appointed by a circuit court for an individual found to be incompetent to consent to treatment. A guardian advocate can make mental health decisions for the individual or may also be authorized by the court to make medical decisions while the individual is on involuntary status. An involuntary examination may be initiated by one of three ways: a circuit court judge, a law enforcement officer, or an authorized mental health professional. A physician, clinical psychologist, psychiatric nurse, mental health counselor, marriage and family therapist, or clinical social worker may execute a certificate stating that they have examined a person within the preceding 48 hours and that they find that the person appears to meet the criteria for involuntary examination, and stating the observation upon which that conclusion is based. If other less restrictive means are not available, such as a voluntary appearance for outpatient evaluation, a law enforcement officer is to take the person named in the certificate into custody and deliver them to the nearest receiving facility for involuntary examination.
James Martzoff was deemed a risk to himself during a domestic altercation with his wife. He was transported to a Baker Act facility. During transport, the police officer reported that Mr. Martzoff tried to cut his wrist while handcuffed in the back of the patrol car. Although the wounds appeared superficial, he was transported to the local hospital for medical treatment. "It happens," commented the transporting officer. "People try to hurt themselves, like cutting their wrists, thinking it will keep them out of the Baker Act facility. It doesn't work."
A patient is then to be examined by a physician or a clinical psychologist at a receiving facility without any unnecessary delay. They may, upon the order of a physician, be given emergency treatment if it's necessary for the safety of the patient or for others. The patient may not be released by the receiving facility or its contractor without the documented approval of a psychiatrist, a clinical psychologist, or if the receiving facility is a hospital, the release may also be approved by an attending emergency department physician with experience in the diagnosis and treatment of mental and nervous disorder, and after completion of an involuntary examination. However, a patient may not be held in a receiving facility for involuntary examination longer than 72 hours. This concludes the coursework for Module 1. Do you know the definition of suicide and other related terms such as suicide ideation or suicidal behavior? Are you familiar with the relationship between depression and suicide and how that affects Baker Act admission? Do you understand the Baker Act process for both voluntary and involuntary admission of patients who display the signs of depression and suicidal behaviors? Do you understand the general risk factors involved in suicide and the specific warning signs for the different populations? Which warning signs require immediate action? If you can answer these questions, then you're ready to go ahead and take the knowledge review. To complete the knowledge review, go back to the M1 tab and click Open Module 1 Knowledge Review. After completing the knowledge review, you may decide that you need additional study of this material. If so, return to the beginning of the module. If you correctly answer 16 out of 20 questions on the knowledge review, you may go on to Module 2, the M2 tab.